So good morning, everyone. At the onset, I would like to thank AIOC for giving me
Start the timer, please.
And my paper is on the next generation cross-linking calculator for titration of energy in thin keratogenic cornea. I have no financial disclosures. The management of keratoconus, along with its safety and efficacy, has been well established by a previous published work. So, what is the management commonly used for more than 450 microns? That we can go for an epi on KXL and or an intracorneal ring segments. For advanced disease or scarring, keratoplasty is required. So what about the thin corneas without scarring presenting to our OPDs? How do we proceed in those cases? So we can go ahead with a standard cross-linking, or do we post for a keratoplasty? So studies have shown that the cytotoxic effect of combined riboflavin and UVA treatment is reached at 400 microns stromal depth. And on the other hand, corneal transplants with the best of the surgeons have a limitation of graft survival. So in this paper by JAMA Ophthalmology, they have shown only a 17% graft survival at the end of 23 years. So what are the other modalities? Are hypoosmolar riboflavin, transepithelial method, crosslink, contact lens assisted, lenticule assisted, customized pachymetry guided, and aphoresis cross-linking. But the limitations are that higher order aberrations are not corrected, unpredictable outcomes, and difficult visual rehabilitation. So is there a different way of cross-linking thinner corneas without scarring? So that's when we stumbled upon the paper given by Dr. Hafezi, which gave the sub 400 protocol. So they described the principle of adapted fluence. So they customized the energy of UVA fluence according to the corneal thickness. So a lower dose of UV is administered from the beginning, that is by shortening the irradiation time. So this paper also gave the stress relaxation curves for different conditions and stated that the effect of corneal cross-linking is more dependent on the duration of the UV light than to the overall applied UV fluence. So the graph was derived from a multiple of complex formula, which we fed into our algorithm and developed an NXT UVA calculator. So bringing the mathematics easily to the clinics. So leading us to a research question, is there a simpler way to calculate energy titration and time in thin corneas? A purpose of the study was to evaluate the safety and efficacy of this calculator. So our calculator was derived on the Lambert-Beer equation, so which presented a simple calculator to decide the UV on time for an incident of 3 and 9 milliwatts. So the assumption behind this, that the calculator is very handy and can be easily used by the clinician. It gives a change in thickness and with the change in fluence time. So this is also a chart which is provided with the epithelium of thickness. So with the epithelium of thickness in the first row, the second row is the 3 milliwatt per minute's time and the 9 milliwatts per time following that. With this background, we decided to evaluate the performance of the UVA calculator. And after taking approval for the ethics committee, 70 eyes of 70 patients with advanced keratoconus, documented progression, and corneal thickness less than 400 without any scarring were included in the study. So for each patient, we did a corneal topography to see the progression and the thinnest corneal thickness, the epithelial mapping on AIOC, the specular microscopy to see the endothelial cell count. And then we put everything in an NXT UVA algorithm and did the cross-linking. So for example, if we have a patient who has a TCT of 390 microns, removing the epithelium, we get a 340 microns. This was entered in the app, which gave us the corresponding UVA fluence time of 21.95 minutes at 3 milliwatts and 7.3 minutes at 9 milliwatts of 0.1% riboflavin. So we can go ahead and do the cross-linking. So at 1, 3, and 6 months, what did we see in the patients? That we saw the best corrected visual acuity change, the corneal topography for its stability, the surgical outcomes by the specular microscopy, and the demarcation line by the AIOC. So we had good safety profile. The mean densitometry value with the standard deviation showed no significant change on the 0 to 2 millimeter and 2 to 6 millimeter of densitometry zones. Regard to change in the Snell's line of corrected vision, 51% of our patients had no change. Out of that, then there was 24% and 14% which had gain of 1 or 2 lines, with a very minimal cohort of patients with a loss of line. Specular microscopy showed that there was no statistical significant difference between the specular CD counts before and after the procedure. The efficacy was very well established with the very stable keratometry value of K1, K2, and Kmax post 6 months of cross-linking. A good demarcation line was seen in 62% of our patients, and we had good outcomes as shown by these two topography maps. Regarding to the biomechanical stress indexes, which we see, 65% of the patients had no change and 35% had a strong or a stiffer cornea post-cross-linking. We are in work in progress with the polarization sensitive OCT, which is the PSOCT, which shows the collagen imaging, which is showing either it is not significantly changing or it is stiffening for some of the corneas. So what was known that standard cross-linking is not possible for treating these thinner corneas. What a study adds that it gives an alternate method which is simple, freely downloadable for every clinician, easy to use, and due to the COVID pandemic, the paucity of donor corneas is less and we can shift the patients to a longer term with their corneas. Then limitations is a longer term for follow-up and larger patient cohort is needed. We have also generated a QR code for the ease of the clinician along with the URL password. So thank you.
Thank you, Dr. Ritika.
Thank you.
Yes, good presentation. Any question for Dr. Ritika?
Thanks, Ritika. Good presentation.
Thank you.
Ritika, this actually sounds very promising.
Thank you, ma'am.
And especially since it will be more like an app which can be utilized by everyone.
Yes, ma'am.
So my question for you was that what was in the cohort that you had? What was the thinnest pachymetry that you used?
Yes, ma'am. So the thinnest pachymetry we have gone up to is 320, which gave, we have done a 5-minute corneal cross-linking after this. And to that patient also, we have a long-term follow-up. He is stable and doing a good with a very good demarcation line.
So what are the advantages of your technique versus the ones that are already described? For example, putting a BCL on top or some other tissue on top like the smile lenticule.
Right. So all the other techniques, which are the contact lens assisted or iontophoresis assisted, are good in their own ways, but they do have the limitations that do not give a predictable visual outcome. Most of the studies which have been described in the international papers also are showing that the loss of lines are more, or there is an unstable flattening. So they are not able to gauge the demarcation lines or the flattening effect. In our paper, we have a very stable K1, K2, and Kmax, which is very, very stable for all the patients. A longer cohort also shows that long-term collagen changes are very good in our patients, and we do not lose the biomechanical strength. So 65% have shown that there is no weakening of the biomechanical strength, and 35% in that cohort is showing that there is a stiffer change. So that is what we are adding, that the biomechanics, we are saving it on that, and we are retaining the collagen power of it.
So what is the worst side effect you've seen in your series?
A few of the patients had a loss of line, like 1.4% had a loss of line. That is due to the excessive flattening, which we get sometimes in treating the thinner corneas. So that is just the one side effect we saw, but rest of the patients are doing very well.
Okay, thank you.
Thank you.